Good afternoon and welcome, and good morning to some of you from the West. Thank you so much for joining us for the unveiling of the US FGM Dashboard, a critical tool in the fight against female genital mutilation in the United States. It's wonderful to see so many familiar names among the webinar registrants, our partners and colleagues in the fight against FGM in the US. We appreciate your engagement in this important conversation. Before we get started, here's how you can participate. You know the drill. You may submit questions at any time using our Q&A box at the bottom of your screen. We will dedicate approximately the last 20 minutes to answering any questions and trying to get through as many as we can. Following the webinar, we will send along a recording of today's discussion to everyone who registered. The US FGM Dashboard was developed by AHA Foundation's senior researcher, FGM expert and advocate Sean Callahan, a PhD candidate at the University of Leicester, where his research explores FGM in diaspora communities in the United States. He is also the author of AHA's groundbreaking report, FGMC in the United States, which was published back in 2023. Today, we want to gratefully acknowledge that the US FGM Dashboard was made possible through funding from UK Research and Innovation and the Economic and Social Research Council. It is developed and hosted by the University of Leicester. When Sean and I first began discussions around the possibility of him conducting FGM research here in the United States, this is exactly what he and I envisioned, that we would eventually be able to share it with others who are working with us in this field in a way that would help all of us most effectively target our work. I am so excited that today we are able to do so. Thank you, Sean, for everything, and welcome.
Thanks, Amanda. Great to be here with you. Thanks, everyone. Hi from just outside London in the United Kingdom, where it's the evening. Good to be with you.
Yes, and good evening. Sean, I think it's best to begin today by looking back. Yeah. In October of 2023, we published our report on your research outlining the prevalence, distribution, and impact of FGMC in the United States. Please tell us what were your key findings from that research and how they were calculated.
Yeah, so our goal with that project was to really establish the scale and distribution of FGM in the US, and really to update the 2016 report that CDC did, which most people were quoting up until this report came out, of the 513,000 women and girls potentially impacted by FGM. And we wanted to build on that work and really try to understand the impact of migration and acculturation on those estimates. And one of the things that they acknowledge in their report, in the CDC report, is that they didn't take that into account. And then also to segment that population into those living with FGM and those potentially at risk of FGM, because 513,000 is a big number, but how many are actually at risk? And so we were trying to do that in that report. And so, lots of calculations, which I don't want to bore you with, but just the quick headlines. What we found was about 1.3 million women and girls that were connected ethnically or through birth to countries where FGM is practiced. Of those, 940,000 were born in those countries and migrated to the US, and 385,000 were born in the US. We took those numbers and we pushed them through multiplied them by the prevalence in those countries where of origin, and estimated that about 332,000 were likely to have been cut before they migrated to the US. About 88,000 were at risk in and around that age of migration or post-migration, and about 156,000 were potentially at risk of that 385,000 born in the US, which gives us a number of 577, which is our updated equivalent number to the 513,000 that CDC developed in their study. And this is on data that's a couple of years after the CDC. The CDC's data was on the 2012 population. So this is on the 2019 population. So that makes sense, that 577. But we then wanted to say, well, how much does migration impact on that and acculturation? So we take that 577 and we say, well, those who were cut before they came, migration had no impact on them. They were cut at whatever prevalence it was back home. So, if they grew up in Somalia, there's a 99% chance that they migrated cut. And if they grew up in Nigeria, there's a 19% chance that they migrated cut. And then those that migrated before the age of cutting in their country of origin, we made the assumption that migration and acculturation would reduce their risk by half. And that calculation was based on a whole lot of other studies that have been done in Europe and some that have been done in the US, including the NORC study that was published by CDC. That they speak of this drop-off post-migration. And then those that were born in the US, we assume that the drop is 75% from what it was back home. So again, taking the Nigerian population, if we start with, let's call it 20% for the maths to be easier for me, at 20% who migrated as adults likely are cut and therefore form part of this number. Of those who migrated young, maybe 10% of them end up being cut, and those who are born in the US, maybe 5% end up being cut. And so we end up with 415,000. And that we then broke down into those that were living with FGM, so are now currently over the age of cutting, 485,000, and those that are at risk in 2019 of being cut, about 31,000. So that breaks us down into those sort of broad numbers that this report spoke to. And so that then, gives us a sense of what we're trying to do.
Thank you. And today we are talking about mapping these numbers.
Yeah.
Why did you decide to include this mapping tool in your research of FGM in the US? What drove that decision?
Again, 31,000 is a number, but where? 31,000 out of 600 million, is that 300 million Americans? That's a number, but it's a number that's like, where do we find them? Are they concentrated in specific communities? Where are the 385,000 women that are living with FGM? Are there certain communities where they're going to need specific health care provision and so on? And so trying to map that out in that report that we published in November 2013, we were able to do it at the sort of at the state level, and you can download these 2-pager off the website. If you just scan that QR code there on the site now, you can get to the link where that report is. These give some breakdown. So we have in Illinois, 37,000 women and girls from those communities, of which about 9,000 5,300 living with and 580 at risk of. We've got some information that on legislation. We break that down further in terms of those three population types, the study population living with at risk by county and by metro area. But, we wanted to get more granular than that still, which is why we then ended up with the dashboard.
This is pretty detailed information already, Sean. Why more granular?
The mapping tool was created to really assist organizations and professionals working directly with survivors and the population at risk to really help to identify those high-risk communities, those high-risk areas, and enable you to provide targeted resources and prevention efforts more effectively. And I think really in the context of always going to have more need than we have resource capacity, to be able to really focus our resources on communities is so important. And so, if I look at just what the dashboard can do before I actually pull it up, we can take that that population from Illinois and break it down to the county level. And immediately we do that, you can see once you get to the spatial that really we're talking about the greater Chicago area. And again, if we then zoom into that, we get to the sense of, well, we're really talking about the sort of North Chicago area. And that immediately starts to focus things. The question then is, what are the zip codes that area talks about? What are the medical facilities in that area? What are the schools in those communities that likely we should be looking at focusing our programming on? Well, we put all of that into the system as well. And so you're able to really get down into some quite detailed analysis of where should we do our programming. And I know this is exactly what AHA's done with the federal grant, that program that you're working on, is take this analysis and therefore let that drive what we're doing. It also is obviously then telling us something about we're still here at Cook County. At the Cook County level, we know that we're talking about this is the living with population, almost 2,000 Nigerian women in Cook County living with FGM, and just over 1,000 Egyptians and Ethiopian Somalis, etc. And we've got the age breakdown of those living with, and maybe potentially surprising to you that there are an estimate of 150 girls under the age of 15 already living with FGM in the county based on the age of cutting in the communities that they come from.
This tool is so incredible. I'm so excited. Go ahead. What were you going to say?
I was going to say, maybe it's time to actually show you the real thing.
Absolutely. I was just going to ask you about how you can use this dashboard to help professionals providing direct services to survivors of FGM. And you took the words out of my mouth. Working with you on the data is exactly how we were able to target where we wanted to do our work in Chicago as part of our work through the federal grant.
So, I'm not going to do this as a complete explainer on everything to do with the dashboard, but this little I button over here takes us to another screen that has information about how we developed the analysis and all of that. But we've got these four main colors, and that's the first thing to kind of get your head around. Is we have the study population, which is that community of women and girls in the US who have ties back to these potentially impacted communities. It's not at all saying that these girls are are living with FGM or at risk of FGM, but simply that they come from communities where FGM is practiced. And again, just by looking at that, we can see that Texas, California, key places, and we can see that the ethnic breakdown, and we can see the age breakdown, and within these sort of bigger 0 to 14s, we can see the numbers and the percentages at the level at the 5-year age groups. We've also got the living with population, and again you can see that skews more towards California. Yes, still Texas, but we've got the girls at risk population, and that clearly skews up into Minnesota. And then we've got those potentially living with type 3 FGM, which we know would require additional health support. And so, again, that skews up into the Minnesota area. That's all interesting at the state level, but that's not really where we want to be. So what we can then do is we can zoom right in. So let's go back to Chicago where we were working earlier. So we can literally just zoom in. And I can click on that Cook County again. And so we have exactly the screen that I showed you a few minutes ago. But I can then flick through it. So I can see in Cook County, what is the actual population that we're talking about. 9,000 Nigerians, 2,500 Ghanaians, etc. I can look at the girls at risk in Cook County, and again, the ethnic breakdown, the ages at which they are at risk. So 177 girls at risk in the first 4 years of life, 60 girls at risk in the 10 to 14. And of course, that breaks down to different school years. And so that tells you potentially which schools to work on. And then, of course, those living with type 3, there's 800, but it doesn't tell me very much. It's kind of spread out, across the county. But I can zoom right in. So just getting into that community, that type 3 is pretty scattered across the whole of Cook County. The at-risk group, well, that's quite different. That's taking me clearly up into these northern neighborhoods. So let's go to this one that seems to be more of an at-risk community. So this is Chicago North, Edgewater. And we can see that we're talking about those 87 are Ethiopian and Somali and Malaysian and Eritrean. We can see that most of them are at risk in this 0 to 14 category. And a lot of them at risk below the age of 5. We can also look at the living with population within that community and get a sense of, well, if those women are living with FGM in this community, then they're going to need support. And again, we can see that they are concentrated into that Edgewater community. So two things that we know is that a lot of the budget decisions are either made at the state level or they're made at the county level. And so getting these county level kind of data points, in order to apply for a grant or whatever is really important. But interventions are going to be happening at the neighborhood level. So getting down into that neighborhood and then understanding which zip codes is that, or, which hospitals, since we're in the living with population, which hospitals are we talking about that are in that community? And so we've got this Thorica Memorial Hospital. I've got the phone number. I've got the actual address. So that gives me somebody that I may want to go and spend some time with. And then those at-risk girls, which schools are in this community. And we said that a lot of them are below the age of 5. And so I probably want to go to, and then the next group, let's just see, the next group are in that sort of 5 to 9. So I do probably want to go to a school like this, PK to 8th grade, in order to focus on. And so again, an address and a phone number. Now, that's available in every community everywhere in the US. If I just zoom in, I mean, this is one that we all kind of know. So, type 3 would be big here. What hospitals? Okay, I really need to think about training for medics around infibulation in that context. Let me stop there. I'm sure I could go on for forever, but
So I think it's clear, likely to most of the professionals on this webinar, that if you see which populations are living where and what age groups they are, you can then begin to think about interventions that are there to support those survivors, particularly living with type 3, or to protect those girls who are highly likely at risk of FGM. And I think that the opportunities for all of us to use this data are just really endless, as far as using it to see, to prove a case for needing funding, and also in order to get those programs up and running in neighborhoods around the US. And just circling back to what I said at the beginning about how you and I always envisioned that this would be a tool that could be used by professionals across the board who are working on this issue. The AHA Foundation is doing amazing work, but we know we can't be everywhere. And we know that there are tons of organizations out there that are also doing amazing work. And we really always wanted and envisioned that this tool would be available for other organizations as well. So with that said, how can someone gain access to the dashboard?
So I think the first obvious point here is that while this is all publicly available data, and we have curated that data into something that is potentially dangerous, could I say, even, and we wouldn't want it to fall into the wrong hands. And so, we really want to limit access to the data to those that are going to use it to fight FGM. And if you're a direct service provider, if you're an academic researcher and would like access to the data, to the dashboard, then simply type in fgmdata.com into your browser, and you'll land up here. And there's a little disclaimer form, and you just hit the request access, and it's going to ask you for your name and email and organization, and just ask you to attest to that you're going to not share your login details. You're going to not share the contents of this inappropriately, and that you've read through these terms of use, and that will ping something to us, and then we'll look at that and decide, as the great overlords of data control, to give you access. And that takes us a couple of days to just do the checks that we need to do to just make sure that we're giving this to someone for the right reasons, and then that sets up and then you would just come back in here, and when you log in, it just asks you to put in a a one-time password, which will ping to your email address. So, just trying to manage access and access control as best we can. And then once you've got that, you get access to that.
Amazing. Yes, we were conscious from the beginning that this is something that we certainly want to make sure that it's not going to anyone who would use it for something other than the purpose for which it was intended. So I'm really happy that we found a way to be able to do that. And we have a lot of questions coming in. So I think that it is time to move over to some of those questions. And so I'm going to just go through one by one and we'll see how many we get through, Sean. So
Great.
The first question I will ask you is, how can a school nurse support students without overstepping boundaries? And maybe we both want to chime in on this one.
Yeah, I mean, it's really challenging. I think we really want to we want to think in the same way as you would do a risk assessment on any child for anything. You need to do the same process here, not assuming anything, and not assuming that this child is at risk, not assuming that this child isn't at risk, but just doing the risk assessment in the same way as you would any other risk assessment. And yes, these are factors that are contributory to that, but not every child is at risk. Even not every Somali child is at risk. While it may be true that almost all Somali children are at risk if they grew up in Mogadishu, most of those children growing up in the US are not at risk, but some are. And so, just thinking through that risk assessment process is really critical.
Thank you, Sean. I would also add to that AHA Foundation has done extensive work providing trainings for professionals, for school nurses and for nurses, for example. And we have an online course for school nurses. And please also feel free to reach out to us at info@theahafoundation.org for more information on that. But I won't take up more time. I think that was a great answer. Next question on our list is, survivors of this abuse are in need of rehabilitation and healing. Even becoming an advocate for other women is empowering for the survivor. As for the abuser, though, is there an effort to arrest and prosecute him/her, stopping further abuse?
Yeah, in our report, we look at the 7P framework, which I think is a helpful way to look at this. So, that I'll quickly unpack them. So the central P is understanding the prevalence, understanding that, are we talking about 5? I was doing a conversation with Hawaii the other week, and it was like, there is a number, but it's a really small number compared to Minnesota. So it's just like, let's put the number in sort of perspective, first of all. Second, that then is to think about, in partnership with the community that's affected, you really need to think about that, and develop policies in partnership in the context of the prevalence. So get those 3 circles to connect with each other. And then think about 4 ways to intervene. First and foremost, how do we prevent this from happening? And across the world, we know that the most effective ways for communities to abandon the practice is through a process of conversation, through a process of dialogue. And so as an outside agent or as somebody working with a community, how do we help to facilitate that open dialogue around FGM and around the place of girls and around what's happening with women in this community, and really get that conversation going rather than kind of coming in with your point of view into that. Secondly, to then think, what services do the vast majority of of survivors of the impacted community are those who are living with FGM, 385,000 as opposed to 31,000. So what services do those women need in terms of healthcare, in terms of psychological support, in terms of relational support, in terms of support around, just things that we take for granted. Somebody said to me, a survivor that I was talking to a couple of weeks ago said to me, I really have to think about where I live and how often I take public transport because I am so susceptible to UTIs given what's happened to me. I really have to think so hard about that. And if I take a long bus trip, can I afford to go to the bathroom on the bus? And, all of that is just, so services is not just healthcare. It's really this whole social service that we need to wrap around and make. And so, really think that through. So what is the provision that is needed? Then, how do we prevent? How do we provide? Then think about how do we protect? And how do we protect in a way that is not seen as stereotyping, not seen as victimizing, and that is done in collaboration with the community and through conversation and so on. And finally, prosecution. And there's state laws, there's federal laws, there's criminal and civil processes that can be taken into place. In many countries around the world, FGM isn't even necessarily a named offense, but quite honestly, it's quite easy, I think, to make the case that it is physical child abuse, that it is assault and battery, and so we don't need a specific law. I don't think there's a single country in the world that those things are legal, and therefore FGM by definition is illegal everywhere, and therefore potentially prosecutable everywhere. But in order to make a case, you have to, there's the whole burden of evidence, which makes the other three strategies much more important.
Thank you, Sean. And I love that you are making my job easy for me and you went through the entire list of recommendations and strategies from the report. I would add to that just a few quick things. One is that I would say that it is important to have specific laws against FGM because of different things around intent and the law. And, it is possible to use other laws. However, without getting into the legal side of it, the most important part of a law and the most important part of our work is to prevent rather than to punish a perpetrator. And I will say that I know that is the stance of even the law enforcement, the federal law enforcement that's working on this in the US, is that their work is on training and in trying to prevent this from happening, in addition to bringing perpetrators to justice. The next question here is, will there be a media release accompanying the reveal? And I just want to say that was a good idea. We didn't think about that, and we will do that. Another question is scalability of this dashboard to help the global South. Is that something that is in the works or possible?
Oh, you speak my language. Yes, it is potentially. It's definitely on my to-do list. We have a lot of data at the county type level for prevalence and of course we have population data, so we can get to actual numbers for pretty much the whole of Africa. And the other piece the other part of my day job, besides my work with the AHA Foundation, is FGMCRI.org, FGM Research Initiative .org, and that website is pretty much 99% Global South focused. And at the moment, it doesn't have this kind of database, this kind of interactive mapping in it. But that is very much something that we're looking at. If you go onto Girls Not Brides and search for their atlas, their interactive atlas, you'll get a sense of something of what we're trying to build at FGM that would give us an equivalent type of data set to this for the Global South. Yes. I'm also talking to Canada about doing something like this in that context. And at some point, I do need to talk to the European network about doing something there as well.
And this research is coming on the heels of us seeing your work previously in the UK. So
yeah.
Next question. I'm working on survivors' expectations of healthcare workers and would therefore appreciate specific information, if it exists, answering this question. Examples of disrespect or lack of knowledge of FGM among clinicians would also be appreciated. So I think if that person is listening in, and we can shoot them an email too. All of us in this field have heard horror stories of survivors going to a healthcare provider and having that physician call in other medical providers to participate or witness the exam, because it's not something that they maybe have seen before, and they wanted to use it as a learning experience for their colleagues or for someone who makes a face even, or just responds in a way that makes that individual feel less than human. And we can talk more about specific examples via email if you'd like, but we have all heard pretty horrific examples of this.
Amanda, maybe just a couple of things to jump in there on. There's actually quite a good body of data, in the academic literature on this. If you just go to Google Scholar and type in that question, you'll find, papers that they pretty much all say the same thing. And I'll just say it, which is the thing that Amanda's just said, that, healthcare providers do struggle with this, and as a result, patients do have quite often a negative experience. I think the way to frame it is pretty much every medic would have been taught trauma-informed healthcare in the context of sexual assault. And so while I don't want to put this into the sexual assault frame, taking that mind and just saying, if I had to do anything I'm about to do, would that be an appropriate thing to do if this was a sexual assault victim? And if the answer is no, then don't do it. And if the answer is yes, then do it. I think that's a pretty good, or child abuse frame, like using one of those frames to overlay on your patient engagement would be helpful. And medics know that, so it's just about connecting those dots for them, I think. And then just one piece of research that I'm currently just finishing up here in the UK, we did and a piece of work I'm just starting, actually. So we did a survey of 800 and something medical students across the UK and asked them questions about FGM. And the headline findings, and it's a paper that's currently working its way through the publishing process at British Medical Journal, but the headline findings are that most medical students, by the time they graduate, would be able to recognize and anatomically understand what FGM looks like in front of them, but almost all of them feel culturally incompetent to have the conversation. And so that cross-cultural comms and just kind of, how do I have this hard conversation, is a big piece of learning that they seem to not get from med school. And so again, as a training provider, maybe that's something to think about. And I'm just going through ethics approval on a project where I'm looking to survey OBGYNs in the US and in Europe, Canada, Australia, New Zealand, to ask them about how often if they've ever engaged a patient with FGM, and what information they have and what their sort of learning needs are. So I'm hoping that will launch after Easter, and we'll get that out into the market.
Incredible. I think this next question is a really good one for you to take on, Sean. It says, I'm ill at ease with any statistic for Nigeria rather than for a specific ethnic group, since it's not the nation, but the ethnicity that counts, isn't it? What do you think?
Yeah, Toby, I saw that question. Yeah, great question. And the same would be for Ethiopians or Kenyans, and pretty much every other community in the data set. The extent to which we were able to address that, we did. So we do run into the limitations of the data, but for example, we know that prevalence in the Somali community in Kenya and the Somali community in Ethiopia are equivalent to or very similar to the prevalence amongst the Somali community in Somalia, in the high 90s. But the Kenyan average is 14.8%, and the Ethiopian average is 65%. So we segmented for that where we could. So we started by saying, does this person identify as Somali, and rather than were they born in Kenya? So we kind of did that segmentation in the data set. That was not possible with the Nigerians, because the data set did not ask, are you a specific ethnic community in Nigeria, and it did not record that. So we weren't able to do that with the Nigerians. And so you're absolutely right. Nigeria is not Nigeria, is not Nigeria. So we know that the average prevalence across Nigeria is 19%. We also know that it's as high as 60, 70% in some communities and as low as 0 in others. Interestingly, the study that was done in Milan a couple of years ago and looked at prevalence within the Nigerian community identified that in that study, the Nigerian community that had migrated to and were living in Milan, prevalence was about 65% in that community. So it's not always the case that it may be lower. It can also be the case that it may be higher, but you're absolutely right. The population data just didn't give us the granularity to be able to do that. And it's significantly better in the US than it is in Europe or the UK or Canada. So it's not going to get better when we go to the other parts of the world, it's sadly.
Okay, next up. How, if at all, do you account for US-born individuals who are not from cultures that historically engage in FGMC? I recognize this would be very challenging to address. If it is not yet, is it a goal for the future?
Yeah, so there's 2 communities that I think we can talk about that are not included in this data set. The Dawoodi Bora community, which we know live in the US, and we did account for them in the report, but they are such a minority of a minority within the Indian and Pakistani predominantly communities, and possibly were born in Uganda but have Pakistani heritage and now live in the US. and or maybe it's 0 point something percent within that, it wasn't possible to include them in this. Or in the written report, we did do some analysis and showed that there were about 5,000 women and girls potentially impacted within that community within the US, and we identified the states and counties where the mosques were, and therefore where those communities were potentially centered. And we did some analysis, but not at this level. And then the white community in the US, that we know there's evidence of FGM within some of those communities. That's not at all accounted for in this data set. Again, we honestly at this point don't know even the scale of that. But the 5,000 Bora community, if you put that in the context of 400 and something thousand, we're talking about 1%, 2% that's going to change here. It's a number, but it's not included. It wasn't possible.
Could you please expand on the impact of migration on the practice of FGMC and explain how you reached 50% and 75%?
Yeah, great question. And I've been doing some follow-on studying on that, and I'm wading my way through interviews and surveys at the moment, trying to understand all of that. But essentially, if we take those, let me pull this over and just put that slide up here so that everybody kind of sees what I'm talking about. So if we take this 577,000, that 577 is made up of 332, 88, and 156. That's how we get, just adding those three numbers together gets the 577. We know that this 332 was calculated based on what percentage of these women were likely cut before they migrated. So there was no impact of migration on that because they were likely cut before they were migrated. This group, it seems rather arbitrary. Let's chop that in half, and then this group, let's chop it in half again. There's about 30, 40 studies across the world that have tried to understand this and done interviews with different people. And they broadly land on these numbers. So, I actually did, 10 different scenarios. On the one end, assuming absolutely no impact, and so you end up with 577. On the other extreme, assume total impact. In other words, if you left the country, this didn't happen. If you're born, this didn't happen, which lands you with 332, and somewhere between 332 and 577 is likely to be the real number. And so we, these are stop points along the way. There's really two big ways, and I think the "and" tells you that. So migration does have an impact in the sense that some people will simply say, having moved away from the social construct where this was happening, I no longer do it, or having moved to a place where laws are much more reinforced, I don't do it, or moving away from a place where kata is, I really can't do it, or I would have to go back to do it. I'd have to go on holiday cutting, or so there is an impact. The question is the scale, but there is an impact that comes from the migration. And then in terms of acculturation, I think we can think of it not as a continuum. Do I become more American and less Nigerian, but rather how American am I and how Nigerian am I? And just because I'm really still Nigerian doesn't mean that I'm still pro FGM, let's take Somali because maybe it's less, or Sudanese, or Egyptian, where most of the community is doing it back home. Just because I'm still traditionally Egyptian doesn't mean that I haven't taken on board some of what's going on with with a different worldview. And so, so those add up to these nuances. It's never going to be exact, but if you look at the NORC study, the CDC study that came out of the University of Chicago, was it? The NORC one that came out last year, they talk about half their respondents hadn't had FGM, and the half that do, most of them didn't want it to continue. So you start to see, but there were some that actually said to them, yes, we think it should continue. So you can see those numbers are broadly here in terms of most didn't, but some still want to. And I think that's, going back to the protection question, that's really the headline message here, is that that most of these girls are not at risk, but some are. And the real question is, how do we assess that? And I think, one of the things that's coming through in my other research is that communities that tend to enclave more, whether it's geographically enclave or socially enclave, where they kind of exist within the bubble of I'm sort of everything. I haven't really left where I was, and I'm just sort of in that bubble, that the social norm is quite strong still inside that bubble. And often all the pieces that I need to kind of make FGM happen are inside the bubble. And we see that even in the evangelical community in the US, that inside the bubble. And so it's like, those more enclaved, I think the risk is higher. The communities that are more connected, they seem to be more acculturated and therefore less at risk. But we're definitely in the place of art and long left the science at that point.
Art in the data. I think you've kind of answered this, but I'm going to combine a couple of questions here. The first one is, what tools did you use to get these reports? And then a different question that I think is related is, if additional known FGMC is identified, for example, through a screening at an OBGYN, are there ways providers can share that information so that this resource can remain up to date?
Yeah, it's a great question. And it's kind of a little bit like the question that the Hawaii group were asking me, is like, who are the 104 people that you spoke to? And it's like, I didn't speak to the 104 people. It's all math. So the equation is, you take this population and you multiply it by the prevalence. Let me find that other slide. You multiply it by the prevalence in the country of origin. So you take the census data and you multiply it by the census data in the US, and you multiply it by the prevalence back home. So if this person was living back wherever there is, maybe it was where their parents grew up or where they grew up, if they were back there, this is what is likely to have happened from them. And that data, the prevalence data, is coming from 81 different surveys that are done by DHS, demographic health surveys, and mix UNICEF surveys, and a couple of national statistical surveys. So we took all of those numbers and crunched them down and said, what are they saying about the prevalence of FGM within the population in 2019 in the country of origin? And then we're saying, what is the prevalence of that community in the US in 2019? And we took those two and multiplied them together. And then we said, was that person born overseas and migrated late? In which case, let's not change that number. Were they born overseas and migrated early, in which case let's halve that number. Were they born here, in which case that's 3/4 that number down. And then we took all of that and said, how old are they now? And what does that mean now being 2019? And what does that mean in terms of, are they now likely living with, or are they now likely at risk of? So it's all maths. So adding new these aren't counts of incidents. We didn't go around and count 31,000 girls at risk. We didn't go around and count 380,000 women living with. So adding new incidents doesn't add to this. What would add to this is a new census data set, or a new set of prevalence data that's coming out of the, and the reason why we did 2019 was because that was the last time that the census data was not impacted by the skewing that happened during the pandemic. We're getting back around now to a new set of data that will come out in the next year or so that will have been collected after the pandemic, and therefore we'll be able to potentially update the dashboard to a new set of data.
Great. Well, we are coming to the end of our time together, and I have to say I am overwhelmed by the number of questions that have come in, and very excited by the engagement and excitement around this tool. I'm going to answer one more quickly and then wrap this up. But I will say that Sean and I will take a look at the questions that we haven't been able to get through, and we will try to respond to those that we're able to respond to. So if I haven't answered your question, or if Sean hasn't answered your question, our apologies. But the next question that I want to address quickly is, would it be possible to add organizations that are working in these communities at a grassroots level? And I'm assuming you mean to the dashboard. And yes, that is 100% one of the communities that, or one of the populations of people that we would love to sign up for the dashboard. So absolutely, please go and register. And I want to, go ahead.
I think that's a double question.
Oh, you read it differently. Okay, good.
So the one thing is, could one of those communities get access to this? Absolutely, yes. Just literally hit the request access button. The other is, could we add something here that populated the services that are available? And the short answer is yes, if we have the data set. These two data sets, the schools and the hospitals, are being pulled directly from the GovUS website. So it's live data. It's literally coming in. So if somebody changes the mobile number, the phone number of their school, it will change live on the here. The extent to which we can put together a service provider list and populate that on, I just add another toggle over here, and then you could see who's providing services in that community.
We would just have to find the data and add it.
Yeah.
Yes. Okay. I want to be mindful of everyone's day today, but thank you so much, everyone, for joining us today to learn about the US FGM dashboard and its capabilities. And a huge, huge thank you to Sean for all of the work that you've done and continue to do on this here in the US. We are all so grateful for it. As we continue the fight against FGM, this dashboard will empower all of us to work smarter to prevent girls from being cut and to support those who have already undergone FGM. Each of you will receive a recording of this webinar in a few days. If you have any follow-up questions, you can reach us at info@theahafoundation.org. And as I said, we will be reaching out as well. And for service providers or academics who wish to register for the dashboard, please visit fgmdata.com. You should have that link in the chat box here too. Thank you so much and have a great day.